Hi, everyone. I'm Donna Fleming. Thank you for inviting me to let me tell you a little bit about our recent experience with a TVAR complex EVAR claims audit at the Cleveland Clinic. So in 2022, the Cleveland Clinic received notice of our required participation in the VQI claims audit for 2021 cases. So we successfully completed this audit, finding we only had one case that was actually missing from the VQI that required entry. However, after we looked at our match rate, we realized we only had an 86% match rate for this module, meaning that we had cases that were in the VQI module. However, they didn't have CPT codes that matched on the billing data that was provided to us. So obviously, we were curious to learn why these cases that we identified through our operative schedules did not have eligible VQI CPT codes. So our overall goal was to investigate the coding of unmatched cases in VQI. Obviously, we'd also like some improved collaboration with our coding and billing to discover opportunities for coding interpretation and improve documentation on our partner physicians to more accurately identify cases eligible for VQI. As a side bonus, we also found there were opportunities for higher reimbursement. And we set ourselves a goal for the next time that we do a VQI claims validation process, we want to bump up our match rate to about 95%. So to go into a little bit more detail, the claims validation process identified 16 cases that were in the TVAR module, but didn't have eligible matching CPT codes provided by VQI. So with the support of our department chairman, the finance department authorized an audit of these cases to be performed by billing and coding experts. So upon review, any miscoded cases, we asked them to recode and possibly be even rebilled. For any cases that they didn't feel could be corrected, we wanted some feedback back to us so that maybe we could improve our documentation and our operative notes. So, of those 16 procedures that met inclusion criteria that did not have a matching code, 12 were ultimately corrected. So 11 of those 12, we found out that they were actually being coded as TVAR extensions, which is a different CPT code, and one was actually a complex EVAR that they had coded as a straightforward EVAR case. And there was actually 4 cases that they felt that didn't need to be changed. So a couple things that we learned. So despite specialty expertise, coding and billing interpretation is a very complex process for vascular surgery and cardiothoracic surgery, which also does TVARs. We learned that operative notes require detailed documentation to assist our coders for accurate coding and billing. And also, ongoing education is also required for coders to fully understand these complex vascular procedures. So the common theme that we kind of saw throughout this process that cases that were actually completion TVARs, like fit for a VQI, they were actually being billed as TVAR extensions, which don't go with VQI. So this resulted in improved identification of VQI eligible cases, and as a side bonus, we increased our vet revenue by correctly coding these cases. And as we know, now when we get higher reimbursement or find money, our administrators are happy. So this was just a little bit of a little screenshot I found about the different CPT code rates. Like as you can see on the bottom, when things were coded as an extension, the technical reimbursement rate was roughly half of a regular TVAR. So you could see, I mean, we definitely had room there for improved reimbursement rate. So the coding and billing department has instituted the following. With finding those 16 cases, they agreed to do an additional review of our 2022 cases, resulting in additional corrections and increased revenue. They also provided internal coding guidelines implemented for frozen elephant trunk procedures and staged thoracic aorta repairs. And documentation improvement feedback is to be provided for TVARs, total arch, and frozen elephant trunk procedures when identified. These cases will be continually reviewed for documentation improvement and coding accuracy.
So we'll take questions after our next presentation at the end of this session.
Hello, I am Jen Harris from Indiana University Health in Indiana, and today I'm going to talk about how we developed a standard inter-rater review process for the VQI registry. We do not have any disclosures in relation to this presentation. Just a little bit about Indiana University Health. We are the largest network of physicians in Indiana. We partner with the IU School of Medicine, and our data quality team participates in numerous registries. In 2017, we centralized our work with the goal of having an abstractor assigned to no more than 2 registries at a time, but would likely have multiple facilities. This allows us to become subject matter experts. So we recognized the opportunity to establish a process to validate consistent interpretation of the data elements between the coordinators. Currently, we have 2 coordinators that abstract for the PVI module. We cover 6 hospitals and over 800 cases a year. We modeled this from our ACC NCDR registries inter-rater review. We like their format, and so we've modified it for the PVI module. Again, for this project, we focused on the PVI module. So we have 20 cases per quarter that we randomly select for re-abstraction, so 10 for each abstractor. When possible, the abstractors did not re-examine their own cases. However, if it does happen, it still provides meaningful data, and especially in catching any keying errors. Overall, we wanted our work to be meaningful, but not overwhelming. So we developed a Teams Excel spreadsheet so that we don't have multiple copies saved. We can both be working at the same time. And we have tabs so that we have our re-abstracted cases in the original abstraction. So we chose patients that just had a single vessel treated. We currently have 48 data elements that we selected for re-abstraction. We picked data elements that had that support our regional quality efforts, such as discharge meds and improving our ABI testing. And then we chose other data elements that we felt had a higher likelihood of discrepancy between the abstractors. So we meet quarterly to review and discuss any discrepancies, and any questions that needed clarification, we emailed to Pathways Support. And then any elements with a 10% mismatch rate or higher, we worked together and created an action plan. We also made notes on our results tab and about the mismatch data, and that really has proved to be crucial for our follow-up calls. Having that data already available for those calls really takes advantage of our time during those meetings. And since it's a spreadsheet, the data elements can easily be modified for any future registry updates or any other data elements that we feel are needed. So as you can see in Q4, we are at an almost 97% agreement rate, and our overall for 2022, we were at almost 94%. So developing the inter-rater review system has been a step forward in making sure we have consistent data between the abstractors. That way our stakeholder can have the confidence that data is being reliably abstracted across all of our facilities. Thank you.
So thank you, Donna and Jen, for your great presentations. Now we're going to expand upon this and talk a little bit about the PSO and FIVOS audits. So thank you for joining us, and I want to introduce Dawn Paiva. She is the Society and Registry Operations Manager for FIVOS, and we'll be talking about the claims validation audits in just a few moments. So just a little bit of introduction. I introduced all of us and what we're going to be doing, but the different types of audits that are currently collected within FIVOS and the PSO, we have what we call claims validation audits, we have data outlier audits, And then we are introducing a data integrity audits, which we will discuss a little bit in more detail shortly. And then after all this, we're going to open up the mics and the questions for our remote folks so that we can have open conversation. So again, I'm going to let Don Paiva talk about claims validation.
Whoa. What did I do, Carolyn? There we go, okay. So the claims validation process, I'm sure many of you in this room today are familiar with our annual claims validation process and have been through it at least once, if not more, especially if you've been here for more than 5 years. This is an annual process, and this is the process that Five O's takes care of on behalf of the SBS PSO. So everything with the claims validation process is run through the Pathways support team. It uses the claims validation tool that is built into Pathways to upload your data, and we match your claims records that you're uploaded against what's been entered into Pathways and develop some reports for you to reconcile that data. The real purpose of this audit is just to eliminate selection bias. It's really important for this registry to capture 100% of the eligible procedures that are being performed at your centers so that we can be confident when we go out and say that this data represents real-world experience. Annually, centers are selected, so all new centers have to complete the claims validation process after their first year of participation. So if you start, but you don't start until after October 1st with data collection in your first year, we would actually hold your validation until the following year. And then a subset of our established centers is selected as well. So randomly, those centers are selected to participate in the full claims validation audit every year. We have a couple of people on the Pathways support team that are really focused on that claims validation process, and we'll talk a little bit more about that tomorrow when we do our Red Ops presentation for Five O's. But if you were doing the audit this year, you would have already been notified in April, and you would be due to complete this in July.
Thank you, Dawn. Before we start talking about the data integrity audit, I'll briefly talk about what I call the data outlier audits. These are the audits that are send notices out to centers that say, we think that there might have been a data abstraction error. For instance, I sent out in 2020 and 2021 some TCAR audits because we had a number of centers that were documenting femoral approach for a TCAR using the en route flow reversal, and that doesn't match appropriately, so I reached out to the centers and asked them to change their data. So that's what we call a data outlier audit. It might just be a data error and abstraction, but our data integrity audits are what we're going to really focus on for the next remaining part of this presentation. So why are data integrity audits important? So we're looking to validate the data that is entered is correct. And you have to remember that any type of gaps in a center's data integrity can lead to misinformed decision-making, and that can impact data analysis, research and publication, benchmarking, and quality of care that's delivered to our patients. Many times these gaps are associated with an understanding of our data variables and definitions, and without a tool to objectively measure the accurateness of the data entered, areas of opportunity for improvement are missed. And just remember that all of these activities that we are doing, the end point is improved quality of care for our patients. The one thing I just want to continuously emphasize that you'll hear me say over and over and over again today, we are using these audits to assess whether maybe the help text is missing, or there are gaps, or they're not clear enough. Or maybe the data element, we haven't done enough education around the data element. So just talk a little historically about the pilot phases that we have done for the data integrity audit. In 2019, we launched the first phase of the data integrity audit, and 2020, phase 2 was launched. During these 2 phases, the PSO used a third-party data abstraction service that was contracted by the selected centers to review completed procedure forms for data accuracy. So they basically looked at, and these were auditors that were already contracted by the audited centers. They looked at the data collection form to make sure that they agreed with how it was abstracted. And I can tell you that when we reviewed the results, that there was a very high compliance, but we only looked at the results on an aggregate level. We did not provide center-level feedback because we are using these first 2 pilots of the audit, as well as this third phase that we are getting ready or have just initially launched as discovery projects, and we're trying to learn what works and what doesn't work. So Melissa Lattis, who is one of the newer members to the team, is the point person or the lead for our third phase of the data integrity audit program. All VQI centers were offered training earlier, and the training will continue as long as these audits run. We are just recently launched the third phase of the audit program, and then after we obtain and learn some of the lessons that we have learned from this, what works well, what doesn't work well, then we're going to launch this into a formal program that we hope, we don't know for sure, but we hope that each center will be audited maybe every 3 to 5 years, just for data accuracy and completeness. Melissa has provided written instructions that are provided to each center that is included in this third phase. They have been notified of their assigned prim procs and directions on how to upload the records into a secure HIPAA-certified environment. And then the audit variables, just so that everybody understands, are selected around our reporting measures, anything that is used for our risk-adjusted calculations, and we also are including variables that are centered around guideline and AUC support. So the audit vendor that we have selected for this third phase will be PSO workforce trained. The audit vendors will be trained on every single audit variable selected by the PSO, and our vendors will be blindly abstracting the cases. So we're going to give them a blank data collection form, and they're going to go through using the records that have been uploaded into the secure portal, and they're going to go through and abstract how they think the procedure went and how the variable should be abstracted. The submitted center-level abstraction prim procs will then be compared to what our auditors abstracted, and there will be a record of matches and mismatches. And then at the end of phase 3, aggregate reports will be provided to all centers that were selected for this last phase, somewhere around the end of Q4 or Q1. So one thing I wanted to make sure that everybody knows, this third phase of the audit is going to be centered on the carotid artery stent registry. 100 centers have been selected, And of those 100 centers, we were asking approximately 10 records to be uploaded for us to do our work to look for matches and mismatches. The final takeaways from this is that these audits are not punitive at all. We are not looking to point fingers and saying someone's doing a bad job or someone's doing a better job than someone else. This is more a tool for the PSO to be able to objectively assess potential opportunities for improvement, such as center-level education or help text enhancement. And just remember that the audits are an evidence-based tool used to validate the data entered by our data managers, medical professionals, and others. So with that, I'd like to start taking some questions for the panel.
So I'll begin. Don, I have a question for you. That was a very interesting finding that you had at the Cleveland Clinic, and it sounded as if you had cases that were entered into VQI that had not been billed, and so essentially the clinic was leaving money on the table. Were you able to recoup any of that? You mentioned that they had rebilled for them.
Yeah, actually, and the reason that we even found these cases, we try to be proactive rather than waiting for a couple months for billing to be behind. You know, we were proactive, we go through OR schedules, so that's how those cases ended up in there. But as far as the money, my understanding is that there is a month, I think 6 months, don't quote me on that, but anything that could be corrected was corrected and rebuild. So I think we did get some of this money back. 2021 was a little harder, but since we found this, we said, well, let's go do 2022. How much money did we leave that we could possibly get back? And I'm sure everybody's in that situation where every dollar counts. So they went for it. So I think we did get some back. I didn't get the exact numbers, but anything that was eligible within those timeframes, I hopefully was recouped.
You know, I don't think it's a unique experience, and I think we found across VQI that about 10% of cases that are entered are not billed for. And we get a lot of pushbacks about the cost of subscription to VQI, the expense of data entry. And we have used this as a talking point for centers that they say, by participating in VQI, you can enhance your billing procedures and so on. And so have you been able to sort of incorporate this into the workflow to prevent it from, continuing to happen as you move forward?
Yeah, I mean, one of the things I was able to gain access to, I mean, I'm really not a coding specialist or even a finance person, but we do have some, through our finance department, set up some Tableau databases that, I can run every procedure by that specific VQI code I'm looking for. And if there's cases on my case list that are not on that billing, I start asking why. And if I find out it was billed at something else, I mean, I've developed a relationship with some of our coders where I could ask them, say, hey, are we missing something in this operative note? And they said, well, yes, it really says that, you didn't go by the diagram, like, for example, an open TAA, or it was noted that it was an extension. And we try to talk it out, and then we can go back to the surgeon. I'm trying to encourage them that if they're not clear on something, please reach out to the surgeon for some clarification, just so that we can make sure we're billing things as appropriately as possible and not leaving money behind.
I do mean to belabor this point, but it's, what I think really is one of the clear financial values of VQI participation. But have you brought this information to, like, the department chair or chief
Absolutely.
financial officer and quantify it and so on?
Correct, yeah, our department chairman was actively involved in that, actually encouraged our finance department to complete this audit, because, it did take some of their times. We have FTEs for the, VQI, but, they also find using a little bit of their time got some money back from that part as well. And that was chaired with our institute chairman as well, Dr. Svensson. And that's why I'm here today, because they approve meeting attendance.
Terrific.
Hi, my question is for you also, Donna. We found the same problem in our institution with the T-bars and the complex E-bars and the simple E-bars. And we did something very similar, and what we found was between the branch iliacs, the simple but branch iliacs, and the complex E-bar, that there was a discrepancy with billing and overlapping, and we communicated with billing regarding on that and do the audit. So I wonder if something like that happened in your institution, and if there was something that you found.
You know, they didn't so much, I didn't find any instances of mixing up, complex branched iliacs with, visceral branch, anything like that. A couple of the cases that I did find that they weren't willing to correct, I felt they should have been billed as like a complex EVAR, like the 34800 series, but they said no because they were an EVAR with like a chimney or something else with stents. So I'm like, if I hadn't been going through the OR schedules, they still aren't correcting those. They say, no, those are more fenestrated pairs, like a Cook Zenith, type of fenestrated. So there's still going to be, I think, a little bit of difference in opinion. But unfortunately, no, or fortunately, I did not find anything with a branched hypogaster branch. How many have you found from?
I found about 7
Oh,
that were having that overlap.
yeah, and I think it's an education thing. I mean, these
Yes.
procedures are extremely complicated, and a lot of billers and coders, they just aren't used to seeing these type of things. So we need to encourage them to ask questions and even perform their own internal audits, because they don't always appreciate someone like me who's not a billing person, like, don't tell me what to do, So,
We exactly had the same issue.
yeah, it's a
And-
little touchy,
Yes.
because it's not our expertise, yeah.
And we have to have communication with the head of the Department of Billing regarding on that.
Yeah.
In regarding the audits, a suggestion, when there is a discrepancy between multiple fields, we cannot tell which field it's the problem. It just comes blank. Like if there was a way that we could say, like, there's multiple fields that are not matching, not just one. Because like we can tell when there's a sex not matching, when the physician is not matching, but when there's multiple of them, we can't tell which ones are. So if there was a way, we would appreciate that. But thank you, great job.
So, Julian, if I'm correct, you're referring to the claims validation, right? And yeah, our matching is limited, so we can give you a close match if one thing is wrong. But yeah, if multiple things are wrong, then it's hard to do. We have, some sites really upload a lot of their claims data for this just to make it easier, and that's a perfectly safe thing to do. We keep it all secure in our environment, and we only use the data that we need to do the matching. And sometimes that's the best way to do to make sure that we get all the cases, right? And we can really reconcile that. But because of that, we are limited in that. But I'll definitely take that back to the engineers and see if there's anything we can do in future iterations to tweak that coding.
Or just label them as multiple non-match. And that way we know that we have to look in several areas, not in just
Yeah.
one.
Okay, thank you.
Thank you.
Got to get it low enough. One comment, one question, please. With regards to the regional reports that you were talking about earlier, one of the things, I'm realistic enough to know that my docs are not necessarily going to download the report and read it. So when you try to save it as a PDF, I'm glad you're laughing because you obviously understand my pain. When you're trying to save them as PDFs or print them off, the colors don't show up. And then they kind of say, well, come back to me. So I'm just wondering if that's, obviously it's a known problem now that you're nodding. And is there anything that can be done, will be done, or is anything to kind of address that, just to make their lives easier?
Yeah, so some of that's dependent on the browser you're using and some like additional setups, but I'll take it back to our statisticians to see if maybe we can't come up with some exportable format that,
Yeah.
that will result in a consistent display.
Because I've tried it on 2 different browsers and it doesn't work on either one. Okay, the second question had to do with the data audits. Because I'm hoping that some of my colleagues are listening to me across in Canada, what is going to happen when our centers, because we can't identify any of our data, is that going to be addressed, or how are we going to be able to send you cases and whatnot? I don't know if you guys have addressed that, but just maybe give a heads up. So we're out of it for now.
You're out of it for now.
Thank you.
We have one online question. If someone is part of a full claims validation audit, are they eligible that same year for the data integrity audits? And the answer is no. We are doing our very best to not have a center have 2 big audits in one year. And if it does happen, reach out to us. It was a human error, and we'll fix it and make it right. Now, centers may cross. So if you're in a large health center and a few of the, if you're part of a large health system, I should say, and some of your centers were selected for the full claims data audit, there might be a few different centers within that same hospital system that are selected for the data integrity or the source data audit program, but we're going to try to not have the exact same centers having to pull data audits for both programs.
And one comment and then a question for Donna. Back in terms of auditing, particularly for these kinds of procedures that are difficult and complex. The first is just remember that time is money when you submit a claim, and clean claims will be rapidly paid. However, when you have to resubmit a claim or provide further justification, that includes workforce hours that are required, and then a delay in payment. So when you're looking at trying to retrieve this type of money, just keep in mind that you've already spent a lot more time and effort in your office and your billing department to capture that same information that would have been available if it was a clean claims submission. So it's very important that the physicians are educated about correct coding, and it's very important that the coders also have communication with the physicians in terms of the codes that are submitted. My question to you is, I was constantly hounded because of my incomplete dictations and processes of submitting CPT codes, and I thought I was pretty good, but I wasn't. And our billers and coders were right next door in our office, so they had an open door policy to us as the surgeons to come back and say, you want to submit this claim, however, you do not have adequate documentation in the operative note or the procedure note for that. My question to you, how often were the billers and coders going back to the surgeons to ask them maybe to provide an augmentation to their operative decision, and then how receptive were the surgeons for that?
Yeah, that's interesting you say that. Years ago, same thing, the coders billers were right down the hall. Now that we've grown so much, a lot of them are remote. They don't really know the physicians as well, may not feel as comfortable going back and questioning. That is something that I've encouraged them to start doing again. With a little bit of pushback, I think some of our coders and billers didn't want to feel the pressure to possibly code or bill at a higher rate. They're afraid of, CMS or, trying to bill for something that they could not justify. So I really did try to encourage them, say, we're not asking you to do it, but if there's something missing from that documentation, can you please let us know? So they do have that billing supervisor now who may be more comfortable going to the physicians directly rather than the individual coders or billers to say, hey, you said that this was an extension, but we think you really mean this. Can you clarify that in your operative note? So we could bill that as a completion as opposed to just an extension. I was also saying that we had issues like with our open thoraco repairs. They kept looking for a key phrase like that they went above the diaphragm, but some of our physicians just wouldn't document that. They leave that part out, again, leaving a lot of money on the table. So we really keep trying to emphasize that in our staff meetings, like, please just add that little sentence. It totally will give them the justification then to bill, and hopefully we'll get reimbursed at a higher rate.
Jen, you're really to be commended for doing your inter-rater reliability exercise there. And I just sort of, and you had a very high rate of concordance, which is terrific. What did you do with the information afterwards? Did you achieve consensus on the discordant areas, and how was that handled?
Yeah, there was a couple instances where we did where we didn't necessarily agree, and so we did email Pathways a couple times, and then the other few times when we had higher disagreements rates or however you want to call them, we just talked it out and kind of said, well, this is how I see our docs documenting, and, sometimes documentation is not very clear, and so we would come up with a solution and say, okay, when they say, lifestyle limiting, this is how we're gonna document it going forward, so that data does become consistent between all of our facilities. But I think we haven't done it yet for this year because we've had some stuff going on, but I do think our agreeance rate is going to continue to get better, and probably, I think, we haven't necessarily set a goal, but I think a goal of 95% or higher is a good attainable goal for sure. And obviously, anything greater than that is awesome.
Just as a source of reference, we have one of our online people said that they were just selected for the Phase 3 carotid audit, and it took them about 20 hours to pull all the records. So I just thought I'd share that with everybody.
Certainly for our registry, data accuracy and integrity is at the heart of what we do. It's, without it, the data is not of much value. So we are going to be, continuing to increase our audits. Most people, when they hear they're being audited, it's like when the IRS tells you you're going to be audited. It's not the most welcome thing you receive. The good news is you're not going to be fined or pay treble damages, at the end of it. And hopefully you will learn something from it, and we will learn something from it, and we'll be able to provide a better product. So thank you for bearing with us.
Hi, I'm Sandy from Yale New Haven Health. I'm not sure if you're able to answer this question, but we have outsourced some of our abstraction and other registries to a third-party vendor. And it's not always optimal. Their abstraction for data integrity, and we are looking at their IRR process as much as we could get that information. So I don't know if anybody here has had that experience with trying to align their IRR process with a third-party vendor, and if VQI has any recommendations.
Well, I'll be glad to comment on that. We have found that many of the third-party commercial vendors are quite accurate. They have a high degree of accuracy, even more so than some experienced coders. When my own institution switched to an external vendor, we double-coded it, and we did it internally in comparison to it, and actually found that they were doing better than our coders, and it was cost-effective for us. So that may be a consideration at the outset. Having said that, over time, this particular vendor seemed to fall off, and we then ended up switching again. So I think to some extent you do need to keep a little bit of an eye on them. But overall, the feedback that we've gotten is that many of these commercial vendors are very good and cost-effective.
Okay. Yeah, we're asked to look at their critical elements because that's what we focus on. We have a 97% IRR rate, and we're not getting that information yet, but thank you.
I anticipate that as this becomes a formal program and we move out of the pilot phase, that we will be providing centers feedback on the audits. Again, it's not punitive, it's just feedback, whether it's areas of opportunity, again, that we see for the PSO, or maybe the PSO needs to reach out to some of the data abstractors at a particular center and do a little bit more education.
Hi, I'm Robin Estino from ProMedica Jobs Vascular. I just had a question regarding the audits. Have you ever considered looking at giving the auditors remote access? I know we have Epic as our EMR, and we have the ability to do Epic Link Access, which provides specific MRN and only specific detailed information that the abstractor or somebody external to our system can access. might be a useful tool and cut down on all of the printing and paper and uploading that happens as far as those other audits. Just wondered if that was thought about.
We are definitely taking that into consideration. Some centers, though, require competencies. You know, they're going to have to complete certain competencies for a center, whether it is sharing of data, and they have to go through certain exercises. So again, I think these are all things that we're learning as we continue working through this process. And we're not done yet. We're still learning a whole lot. We are uploading our data right now into what we call a box environment. It is HIPAA certified, and you know, maybe we're going to find new ways to upload the data that will be more efficient, or allowing the auditors to actually gain access into the medical record, your medical record. We don't know yet. So again, still trying to learn, but great ideas.